ఇదో. Disgrace.
Sir, sir, good morning, sir. Hello, sir. Sir, good morning, sir. Hello, Kumar, sir. Good morning, sir. Screen వస్తుందా దుర్గారావు గారు? ఏదో వదిలేండి మనం హలో సార్. సార్ వీడియో వస్తుంది. యూట్యూబ్ లైవ్ ప్రైవేట్ చేసుకోమను రాత్రి 9:15 కి పబ్లిక్ చేద్దాం. సార్ వీడియో ఆన్ చేయండి మేడం. కళాకుమార్ సార్ ఆన్ చేసుకోవాలి. సార్ వీడియో ఆఫ్ చేసుకోవాలా? అది రైట్ సార్. కళాకుమార్ సార్ ప్రిన్సిపల్ సార్ ఆడియో వీడియో రెండు ఆఫ్లో ఉన్నాయా? స్క్రీన్ మీద ఏం కనిపిస్తుంది? నేను కనిపిస్తున్నానా? నేను కనిపిస్తున్నానంట. అవును, సార్ రెండు ఆఫ్ లోనే ఉన్నాయి, ఆడియో వీడియో.
హలో
సార్, గుడ్ మార్నింగ్ సార్.
రావు గారు, డాక్టర్ రావు గారు, డాక్టర్ అమీనా బి గారు, are you able to hear me?
Yeah, yes sir, I can hear you, sir.
Hello
sir, I can hear you, sir.
Hello
sir, vinipistundi sir.
Are you able to hear me?
Yes sir, yes sir, I can hear you, sir. Yes sir, I can hear you.
రావు గారు,
రాత్రి నా వాయిస్ సార్ కి వినిపించట్లేదు.
I am able to hear you, but it's very feeble.
వాల్యూమ్ సార్ కి లైట్ గా వినిపిస్తుందంట. సరే సార్ కి లైట్ గా వినిపిస్తుంది. Sir, you can hear me, sir? Sir, can you hear me, sir?
Hello
Can you hear me, sir?
Hello
Sir, వినిపిస్తుందా? Sir, వినిపిస్తుందా sir?
Now are you able to hear me?
Yes sir, yes sir, I can hear you, sir.
Yeah, that's good.
My voice is clear, sir?
Amma,
నా వాయిస్ క్లియర్ గా ఉందా సార్?
మీ వాయిస్ కూడా క్లియర్ గా ఉంది ఇప్పుడు.
Thank you so much, sir. Myself Dr. S.K. Amina, sir, coordinator of today's webinar, sir.
Yeah, acha, one more thing,
Sir.
about Amina B garu, have you gone through the slides?
Yes, sir. I have seen the slides, sir.
Is it okay? Do you want me to add anything in between? Because I think this is only for 45 minutes, I suppose.
Yeah, yes, sir. Means actually the program will be starting at 9:30, sir.
Okay.
Yes, sir. Along with validity, the program will be end up at 11 o'clock, sir.
Amma?
Validity to saha 11 o'clock end up అయిపోతుంది, sir.
Okay. There is validity also.
Just a vote of thanks, sir. Just a thanks.
Oh, no problem. No problem.
Yes, sir. Yes, sir. Sir, again 14 more minutes are there, sir.
Amma?
14 minutes ఉన్నాయి, sir, to go on live. ఓకే సార్, మీరు మ్యూట్ లో ఉండండి సార్, నేను మళ్ళీ కాల్ చేస్తాను సార్ మీకు 9:25 కి.
ఓకే నేను 9:25 నేను చూసి నేను వస్తాను.
ఓకే సార్, థ్యాంక్ యూ సో మచ్ సార్. థ్యాంక్ యూ సార్. ఏం respected eminent speaker of today's webinar, Dr. B. Kalakumar sir, members of management, staff members, and delegates from various reputed colleges and invitees, a very delightful morning to one and all. Myself, Dr. S.K. Aminabi, HOD in Pharmacology and the coordinator of today's webinar. As a coordinator, I am very delighted to start this national webinar on novel therapeutic approaches in pain management, organized by Department of Pharmacology by our esteemed institution, VV Institute of Pharmaceutical Sciences, Guddavalle. Pain management provides relief so we can enjoy our life, but treatment is complex and can lead to harmful effects if not properly administered and monitored. This webinar aims to flourish the knowledge about management strategies for pain, including pain relieving medications, physical therapies, complementary therapies, and focusing mainly on novel therapeutic methods. On behalf of our college, I would like to take this opportunity to express my sincere thanks to our Honorable Eminent Speaker, Dr. B. Kalakumar sir, members of management. I thank the principal of various colleges for their support, and I thank all the delegates for their presence and make this webinar a grand success. Once again, I welcome you all. Thank you, sir. Now, I would like to hand over to Dr. A. Lakshman Rao sir, principal and convener of today's webinar, VV Institute of Pharmaceutical Sciences, Guddavalle, to speak few words.
College of Veterinary Science, Rajendra Nagar, Hyderabad. He is also a Secretary General, Indian Pharmacological Society, and dear participants from various pharmacy colleges, a very good morning to one another. It's my privilege to welcome you all to the second webinar of VV Institute of Pharmaceutical Sciences, sponsored by AANM and VVRSR Guddavalle Education Society, Krishna District, Andhra Pradesh. And foremost, let me thank the Honorable Speaker, Dr. B. Kalakumar Garu, for being a part of this webinar. And he is having a sound knowledge and vast experience in the field of pharmacology. And today he will deliver a lecture on the theme that is novel therapeutic approaches in the pain management. And during the COVID-19 pandemic, for the benefit of the teaching fraternity and student community, we plan to conduct a series of webinars in various departments of our institution in association with various professional bodies. And the major objectives of today's webinar are to know the novel approaches in the pain management. Generally, the meaning of the pain is highly unpleasant physical sensation caused by illness or injury. There are several methods that are available for the treatment of the pain. Majorly, the pain is categorized into two different types. One is acute pain and the second one is chronic pain. The pain is affected by various organs of the body. And totally, today, 1037 participants were registered for the webinar for more than 100 reputed pharmacy colleges. Among them, 22 are principals and 78 professors and 119 associate professors and 258 assistant professors and 29 research scholars and 522 student registrations. Thank you all for your active participation. And let me congratulate my colleague, Dr. Sheikh Aminabi, Head, Department of Pharmacology and coordinator for the today's webinar, for her enthusiasm in organizing this webinar. And I wish the webinar a grand success. And now I invite Dr. Sheikh Aminabi, coordinator for the today's webinar, to introduce the speaker to the participants. Thank you, one and all.
Thank you, Lakshman Rao sir. I feel honored to introduce our today's speaker, Dr. B. Kalakumar sir. Dr. B. Kalakumar sir, Professor and Head, Department of Veterinary Pharmacology and Toxicology, TV Narasimha Rao, Telangana Veterinary University, Rajendra Nagar, Hyderabad, and he is also Secretary General, Indian Pharmacological Society. Sir has completed his Masters in Veterinary Science in the year 1988 and he was awarded with a doctorate in the year 2010. Sir started his career as Quality Inspector in Vortex Pharmaceuticals, Hyderabad in the year 1988, Veterinary Assistant Surgeon in Animal Healthcare, Medak in 2001, and acquired many positions from Assistant Professor to Professor and Head from 2013 to till date in PV Narasimha Rao, Telangana Veterinary University. Sir is having 24 years of working experience and supervised 2 research scholars and co-supervised 5 research scholars at PhD level. Sir is a member, editorial board of Indian Journal of Pharmacology, pre-reviewer for DBT projects, reviewer for Journal of Drug Delivery Science and Technology. Sir is a expert member in the recruitment panel of CSIR, IICT Hyderabad, NIPER Hyderabad, and ICMR NIN Hyderabad. Sir is acting as principal and co-principal investigators for various funded projects. Sir has attended 60 workshops and presented many papers in national and international seminars. Sir has published 40 research articles in various national and international journals, and Sir has awarded with Dr. S.P. Pandey Oration Award in the year 2017 from Kite Group of Institutions, Ghaziabad, Uttar Pradesh, and Dr. Lalita Kameshwaran Oration Award 2018 from ESIC Medical College, Hyderabad. Now, I would like to hand over to the speaker.
So, am I audible?
Yes, sir, you are audible, sir.
Yeah, because when Dr. Lakshman Rao was speaking, there was a little bit of disturbance. Okay, but first of all, my thanks to Vivi Institute of Pharmaceutical Sciences, the Department of Pharmacology, Dr. Lakshman Rao Garu, the principal, Dr. Aminabi, the coordinator, because whenever I happen to be in IPS, people get to know me, but the interaction would not be, time would not permit the required interaction, especially with the people in the realm of pharmaceutical sciences. But this is one good opportunity. I'm able to see so many names being splashed on my screen. So and so pharmaceutical college, so and so pharmaceutical sciences institute, and all that. It's very, very a pleasant opportunity for me to interact with all the pharmacy people, because Indian Pharmacological Society was founded by our ancestors who were very much interested in pharmacology and all the branches, that is the medical branch, the veterinary, the pharmacy branch. So all of them, they have contributed their might for the development of the society. So that makes me very pleasant to be with you all this morning. I request each of our pharmacology fraternity to join IPS and make it stronger. Now, unlike yesteryears where we had to depend much on the snail mail, now we are into email, and we can do interact. And that was one of the proposals of Dr. Lakshman Rao Garu, which I think that was the bait that he has offered me. You see, when he said that, sir, this would be a sort of screen raiser, so that we all can unitedly work for the betterment of IPS. I think that put the bait for me. So that's a very good opportunity for me, and I welcome all the participants whoever is waiting there, I still see that 21 people are in the waiting room. So I request the coordinator to admit all of them. And now, if you permit me, we will go ahead with the topic, and then we can have some discussion. Basically, I am from veterinary pharmacology and toxicology. Ours is mostly into the preclinical animal models. So we are into preclinical testing, preclinical development of preclinical animal models, so, and so many aspects, but it's all related to preclinical. Means if you ask me how we can describe the describe this paraclinical courses. That is, we have clinical courses, paraclinical courses. Under paraclinical courses, we have pharmacology, parasitology, pathology, so many things. Okay, but we fall under the category of pharmacology. So, if you ask me to describe a pharmacologist, I say that we are not in the forefront of the battle, but we give ammunition to the to the warriors who are fighting in the forefront, who are in the battlefront. We give them the required ammunition. That's why you see in most of our articles, authors, they use the word therapeutic armamentarium. So we are the people who produce the ammunition, and then we see that it is sent to the forefront. So we do all the preclinical, clinical, and then we say that yes, this drug works and this drug does not work. And thank God, many a time, of course, this may be hilarious, but still, I feel that it is a reality that drugs have adverse effects, so that pharmacologists and pharmacists can survive. If one drug could treat all the diseases, where would we, or where would we be? I think I think most of us we would have ended up as teachers rather than researchers. But because a drug has an adverse effect, a drug has low efficacy, a drug has what at preclinical level it works well, but when it comes to the clinical level, it may not have the desired effect because of the so many ifs and buts. We need to come out with alternates for the existing ones. So in that in that context, with that background, we have this particular seminar on novel therapeutic approaches in pain management. First of all, I would like to share with you. Hope my screen is visible. One of you unmute and please let me know if at all see my screen. Are you able to see the screen?
No, sir.
No.
No, sir.
So it says to collaborate with others, please save a copy of your file to an online location, and yeah, shall I say save to cloud?
Okay, sir.
Now, no.
Share ಕೊಟ್ಟಿದ್ದೀನಿ. Recording ಕೊಟ್ಟಿದ್ದಾರೆ.
Now, are you able to see?
No, sir.
Oh, then would someone help me out as to, because I said share. Now,
No, sir.
now, even now it is no. Why? What happened?
Sir, just to share the screen, sir. Share screen any option.
Yeah, that's what I'm doing, Amma. Share. I've shared it. Is it okay? Is it okay? Are you able to see the screen?
Yeah.
Novel therapeutic approaches in pain management. Are you?
Sir, just you open your PPT and minimize it, sir. Then we can see your screen, sir.
Yeah. Yeah. I have opened it. I've opened it, and you want to minimize the screen?
Just you minimize the video, sir. Minimize the PPT. Minimize the.
Minimize the PPT, huh?
Yes, sir.
Now, is it okay? Is it okay?
Sir, 1 minute, sir. No, sir. No, sir. Sir, can you see screen, PPT on your screen, sir?
Yeah, I'm able to see. I'm able to see.
Just maximize it, sir. Maximize it, sir.
Okay. I'll do that. I'll do that. Oh, here. How అది ఇక్కడ రావాలి. Oh, right. Got it. Just wait. I'm going to solve it.
Okay, sir.
I'm going to solve it. Now.
Yeah. I can see on the screen, sir. Right, sir. Perfect, sir.
Yeah, that's good.
Thank you, sir. Yes, sir.
Yeah. So, right. So, my so now coming to the topic, novel therapeutic approaches in pain management. I am the one who dread pain. Abbo. I'm very much afraid of pain. So that's the reason why whenever I go as an examiner to one of the universities or somewhere else, I carry some good antispasmodics so that the pain does not disturb me while I'm in travel. So I don't like pain. Oh, and but pain is actually it's a somatosensory detection of the noxious stimuli, trying to help our body be aware of the damage that is being caused or likely to be caused, right? So, yeah. Now, let's push these people. 15 people have. Yeah. Now, coming to pain, we have both normal and abnormal pain. Normal pain is protective. That is, for example, if you are sitting by the side of your friend and he has pinched you, and the magnitude of the stimulus is so high that immediately you try to withdraw your hand through a reflex action, and the same pain, it could also be prolonged, which could result in inflammation and repair, right? So but we have the abnormal pain, that is non-protective pain, which is chronic, and it is a part of the disease process. Pain itself is not a disease, but pain is manifestation of the the external manifestation of an underlying disease, right? Now, yeah, coming to the types of pain, we have nociceptive, inflammatory, neuropathic, dysfunctional, and referred pain. Most of the time, we might have encountered referred pain or inflammatory pain, right? Nociceptive, yes, yes, many a time we might even have experienced this nociceptive pain, right? Nociceptive pain through the mechanical sensors, thermosensors, right? Whether it is heat or cold, mechanical, whether there is a prick, whether there is a prick or something like that. So we might have encountered nociceptive, inflammatory, and referred pain, right? Now, coming to the neuropathic pain, today the age, like we say Stone Age, the Copper Age, like that, and this is the Computer Age or the IT Age. So also we have in pain today. It is the decade or it is a century of a neuropathic pain. That's the reason why most of us we suffer with back pain. We suffer with sciatica. We suffer with radiculopathy, oh, so many types of neuropathic pain. So in that context, I thought that I would take all other pains too, but spend little more time on the neuropathic pain. And apart from this, we also have dysfunctional pain. And let us see what it is all about. Coming to the nociceptive pain, it is pain arising from the activation whenever the peripheral nociceptors, are activated, we have this nociceptive pain, right? And here, the primary apparent sensory neurons, these are activated by mechanical or thermal stimuli or by exogenous or endogenous chemical irritants. So nociceptive pain, if you are working in the lab, you have come across the acid, right? And then you have this nociceptive pain, right? So this is a slide showing you the nociceptive sensors, right? I just wanted that this should be removed. Okay, right. It's not going. So you have you have these receptors for signal molecules or stimuli. So these receptors, they would be stimulated. It could be thermal, it could be chemical, or it could be some unwanted pressure or other things. So that from here, these nociceptors are present in the periphery. From the periphery, it is being carried towards the central nervous system where the processing can be done, right? So now, I'm just looking for my cursor, right? Yeah. So here, see, able to see that this is the stimulus, and you have the mechanoreceptor, which senses the pressure, and then you also have other receptors, that is the thermal receptors and other receptors. So they carry these they carry these the pain sensation in the form of signals to the spinal cord, and from the spinal cord to through the ascending pathways into the brain, to specifically to the thalamus, and from the thalamus to the cortex. So yeah, so you have this spinothalamic cortical pathway. In the cortex, the information is processed, and then through the descending pathways, necessary information is sent back. So this is how it happens. And now here, if you see, whenever there is stimulation of these nociceptors, you find that there is production of prostaglandins, bradykinin, um, hydrogen ion, that is the hydrogen ion acid, and also you have the histamine, right? So what happens is that every time the the perception or the pain, whenever the pain is of high intensity, it's not that it is sent to the brain and then one has to wait for the information from the brain or something like that. No, it is not that. If it is too acute, then you have the reflex action. Hope you are able to follow the cursor, right? So you have the reflex action. You simply withdraw your hand or your leg, and that's how that's how you you try to prevent that particular that particular irritant. In coming to the inflammatory pain, this occurs. This is very common. Most of the students, they may have bikes, and they may get injured. So that is inflammatory pain, right? And uh, and this occurs in the presence of tissue injury and active inflammation, and this is characterized by spontaneous pain, right? So you have spontaneous pain here, pain arising in the absence of an external stimulus. And this particular spontaneous pain is seen in case of inflammatory pain, right? The best example is streptococcal throat infection, or a burn injury, or a mechanical injury, or whatever injury that would result in inflammation. So this causes spontaneous pain. And then the second characteristic of this inflammatory pain is that you have allodynia, where there is pain hypersensitivity, right? Many times you might have observed that you injure your elbow or knee, and then um, you come across a very mild stimulus, which in normal cases does not produce any pain. But here, as soon as it touches that particular area, you find that uh, the pain is unbearable. The pain is unbearable. That's the reason why in Telugu we have a saying which says that which says that what uh, every time if there is a wound, then you have you have so many you have so much you have so many injuries, especially on the wound. Actually, the stimulus could be very less, but here what could happen is that here what could happen is that because of allodynia, where there is pain hypersensitivity, you find that the pain is more, especially in case of surgical wound, or either in sunburn, or in normal but in sun in whenever your skin is sunburned, you feel that such allodynia is seen, right? uh, Here, if you look at this graph, here if you look at this graph, you have say non-noxious stimulus, that is physiological. Noxious stimulus, painful, and this is the stimulus in intensity, and this is the pain sensation. Here on y-axis you have pain sensation. So in case of allodynia, right, with what within the threshold, means less than the threshold, you still have pain, right? Whereas hyperalgesia, this is a condition in which you have even in normal conditions, the stimulus is able to produce pain. But in case of hyperalgesia, the same stimulus which produces very mild pain in normal cases, here in this case, it produces hyperalgesia, means the pain that is experienced is quite high. So with that, we have the next slide, that is neuropathic pain. Here you have the pain that follows an injury, or or disease of the somatosensory nervous system. Here, the neural injury produces both negative as well as positive symptoms, right? And also hyperalgesia or hyperpathia. And just now I explained what is allodynia and what is hyperalgesia. Hyperalgesia, you might have seen in that graph that it falls even in normal cases, that particular stimulus which would cause pain. But whereas here you find that in case of allodynia, you find that in normal cases it does not produce pain. The stimulus is insufficient. The magnitude of the stimulus is insufficient to produce pain, but still it produces pain in the in inflammatory in inflammatory conditions. Now coming to the neuropathic pain, here you have negative symptoms, that is loss of sensation or sensitivity, right? And the positive symptoms are spontaneous pain or paresthesia, and also allodynia, right? And you have typical responses to tactile and cold stimuli, right? If you happen to see at times when you eat ice cream, you feel that there is this allodynia, means stimulus is less, but still you find that it is causing a sort of discomfort to you. It is causing a sort of pain to you, right? And paresthesia, tingling sensation, numbness, the sense of pin and prick. Most of the time, people complain of this. They say that pin and prick. And neuropathic pain is seen in case of HIV, post-herpes infection, the diabetes, and n number. Even it is neuropathic pain is a lifestyle disease. You drive for long hours, and when you suffer back pain and go to the doctor, the doctor would ask you to refrain from driving your motorbike. So neuropathic pain is here to stay, right? And not only that, most of the diabetics, they have this neuropathic pain. So there would be spontaneous pain. I want you to differentiate between spontaneous pain and evoked pain. There is another term called evoked pain. In case of spontaneous pain, if someone is suffering with the sciatica, they can easily identify themselves with what I'm saying. You sleep, and in the midnight, you find that you're suffering with pain. Oh, all of a sudden you're suffering with pain. That is spontaneous pain. Evoked pain, you get up, you walk here and there, or in case of arthritis, if you're climbing a staircase, then you have, because of the movement, you experience a good amount of pain. So that is what is called evoked pain. Whereas in case of neuropathic pain, the character here is that it has what is known as spontaneous pain. You are just resting, but still you have the pain, right? Yeah. And then we have hyperalgesia or hyperpathia, which are nothing but exaggerated responses to noxious stimuli, right? And then we have dysfunctional pain that occurs in the absence of a noxious stimulus, inflammation or damage to the nervous system, right? And this could be due to an abnormally functioning nervous system. The best example under this category are fibromyalgia, irritable bowel syndrome, and temporomandibular joint disorder. Fibromyalgia, irritable bowel syndrome, yes, irritable bowel syndrome. If you are in an executive job like head of the department, principal, university officer, something like that, most of the people they suffer with this irritable bowel syndrome, and it has to do with the enteric nervous system. And fibromyalgia, most of us, we do suffer with this fibromyalgia, especially during the summer months, right? And now coming to the last one, that is referred pain, both somatic and the visceral pain. Visceral, they travel along the same pathways. So pain stimuli arising from the viscera is perceived as somatic in origin, right? Especially if you happen to be a gastric gastric patient suffering with hyperacidity, actually the pain would be somewhere near the esophageal junction, where the esophagus connects with the stomach, but actually you would be feeling the damage would be there, means the acid would be acting on the mucosa, in that the esophageal and the stomach junction, but the pain would be emerged in the back, right? There is no absolutely there is no relation here, because the pain is on the ventral side, and you would be feeling you would be feeling the pain in the dorsal side. So this can be confused, and then we call it as the referred pain, right? Right. And nociceptive or inflammatory pain is called adaptive, because as soon as you remove the stimulus, the pain is gone. But whereas neuropathic and dysfunctional pain, both of them, they're maladaptive, means uh, without an identifiable and detectable stimuli, that is spontaneous pain and hyperalgesia and allodynia, you would be suffering a lot. So you cannot you cannot adapt yourself to neuropathic and dysfunctional pain. Whereas nociceptive or inflammatory, nociceptive, you withdraw your hand, it's okay, right? Inflammatory pain, you take a, anti-inflammatory drug, that's okay. But in case of neuropathic pain, no, it does not work, right? Now, so this is how this is about the pathways that are involved in nociception. Here you have the noxious stimulus, then there would be transduction, right? So the signal is converted into electrical, this one, that is due to the opening of these channels, sodium channels, the calcium channels. So there is transduction, and then this is transmitted, and then from here into the spinal cord, and from here it is projected, and then it is perceived in the cerebral cortex, from the thalamus into the cerebral cortex. That's what I told you, spinothalamic spinothalamic cortical pathway, spinothalamic cortical pathway. So through this pathway, the pain, this is how the sensation of pain moves into the cortex. So when it is processed in the cortex, then you feel the pain. So there is modulation. There is modulation. This is how the relay system works. It's something like a relay. Now the baton is given here, and then it goes to the spinal cord, and from the spinal cord through the thalamus into the cortex. Once again, right here you have a pinprick, and you have the nociceptor over here, and then this is transmitted to first transduction, and then transmission to the spinal cord, and then the projection into the higher centers of the brain. Yeah, that's good. The projection into the higher centers of the brain, so that from the thalamus into the cortex, where where the processing or the pain perception can be taken up, right? And as a matter of fact, you find that there are some reactions to pain. For example, there could be an increase in circulation and increase in breathing, alertness. So you find that in the process, even the autonomic nervous system is also stimulated, right? I have a slide for that, so that would make you easy to understand. So now, what are the fibers that carry the pain impulse to the brain through the spinal cord and through the thalamus, right? You have C fibers and A delta fibers and A beta fibers, and this is the myelin sheath. And you find that C and A beta, they are myelinated, and A delta is unmyelinated, right? Yeah. Now, so if it is right, so you have A beta fibers. They carry these non-noxious mechanical stimuli and proprioception. Proprioception is if you happen to imagine that you are in a classroom, you're coming over there, right? And then as soon as the teacher comes, you stand up and then you sit down. How do you sit down? You just try to feel the presence of the chair with your calf muscles. As soon as the skin or the calf muscles, it comes in contact, and then you feel that yes, there is a chair, and then you sit, right? So that is what is proprioception. A beta fibers, they are involved in proprioception, right? So pleasant touch and position in space, right? And coming to A delta fibers, they are responsible for fast pricking or sharp pain, right? And here, this is A beta is for non-noxious mechanical stimuli, and A delta is for high intensity noxious stimuli, and also C fibers for slow burning and aching pain. Now, one here, there are two types, that is fast pricking or slow burning, right? Fast, here you find that there is pricking or a sort of shooting pain, which makes you dysfunctional. Whereas slow burning and aching pain, especially when there is when there is a mild damage, then you find that there is slow burning or aching pain, right? So now this is how it would be through the nociceptors, through the nociceptors. So now you have these nociceptors, they are connected, and they connect with they connect with the spinal cord. In the spinal cord, you have what are known as interneurons, means a group of neurons that connect a bigger that connect bigger neurons. So you have, but before that, you have this presynapse which releases the transmitter, and here you have glutamate as the transmitter, and you are able to see that there are mu and kappa receptors of the opioid family, and then you have the adenosine, and then you also have a PTH receptor of ATP, NMDA receptor, and AMPA receptor. So all of them, they try to modulate the release of substance P and also glutamate. And we know that glutamate is an excitatory neurotransmitter, right? So, and what are the various channels that are present over here? The various channels that are present are sodium, calcium, and GABA. Sodium, we know that as soon as sodium enters in, it causes the opening of voltage gated calcium channels, and when calcium enters in, you have n number of actions, right? And we also know that GABA is a chloride channel, and it allows the entry of these chloride ions. And when chloride ions enter in, we know that it results in hyperpolarization. This is you just keep it in your mind. So you have glutamate, and then you have local inhibitory interneurons. This is what I was speaking about. And then these local inhibitory interneurons, they connect with the next the next neuron that would carry the information, and this information is transmitted from the spinal cord to the higher centers of the brain. So when we speak about higher centers of the brain, we call them, or we call them as supraspinal. But peripheral, that is the presence of the nociceptors. From here, the pain is being perceived by the receptors that are present here, where the impulse or the impulse is is converted into electrical signals, and then it is transducted and transducted to the level of the spinal cord. From there, it is transmitted, and then it is projected to the higher centers, that is supraspinal centers, the spinal center, the supraspinal center, where the pain is perceived. The perception mechanism, the perception takes place in the cortex. So this is how the process goes on. Peripheral, then you have the peripheral nociceptors, and then connect to the spinal cord. From the spinal cord to the supraspinal center, that is thalamus and the cortex, for the pain perception, right? So this is what I request you to remember. Just that this is onto the periphery, and these inhibitory interneurons, they are present in the in the spinal cord. Let me see if I can take back if I can take you back a little, so that you can have an idea of interneurons. Uh, yeah. Still, let me see. Uh, I had, yeah. Yes, 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 yes. So this is how it is. You have the nociceptors here. They transmit, and then you have this interneuron. Able to see the small interneuron over here, the black one, where my cursor is moving. So that is the interneuron. So from the yes, so this interneuron helps in further transmission through the ascending pathways into the supraspinal centers. This is spinal center, the periphery, the spinal center, and the supraspinal center. Right now, let us get back. Yeah. So this is another slide for our better understanding on uh, yeah. Just a minute. Right. Oh, this is a little bit yeah. Now. Uh, so this is the periphery, right? So from the periphery, I mentioned about A beta, A delta, and C fibers. So, and this is the peripheral nerve through the spinal cord, and here you have the dorsal root ganglion, right? And then you are able to see. Just now I told you that even there would be activation of the sympathetic nervous system. If you can just follow my cursor, see, this is the sympathetic preganglionic fiber, right? And the sympathetic postganglionic fibers, and then there's the reason why you find that there is an increase in circulation, increase in respiration, and also mental alertness, and so many other things, right? So, so you have from the periphery to the spinal cord, and through the ascending inhibitory, ascending pathways, the message is transmitted. Yeah, yeah. Now, so you can see that ultimately from the thalamus and then into the somatosensory cortex. We said that pain is a somatosensory detection of the noxious stimuli. So you have the somatosensory cortex here. So, and this is regarding the ascending pathway. So spinal cord integrates, and then you have the amygdala and um, all other subregions of the brain, and then you have the somatosensory cortex. And coming to the descending pathways, you have the message is the message is sent back, right, through the descending pathways, right? Now, right. So this is what I was saying: heat, acid, mechanical cold, and all the sensory fibers, A delta, C, and A beta. The tactile is what A beta. Just now I told you that it is responsible for the pleasant touch and all pleasant touch. And when I say it is tactile, tactile, well, children when they cry, mom comes and then uh, tries to calm them by patting on their back. Mom slowly pats on their back, and the children they enjoy that, and that is through this A beta, right? Through the dorsal root ganglion, and then you have the release of the transmitter, that is glutamate and CB substance P, and also calcitonin gene related peptide. So from here it is sent to the higher center, that is supraspinal center, right? Uh, so once again, the central connection, that is, in case of acute pain, you find that glutamate is released, chronic pain substance is released, and you also have pain inhibitory neurotransmitter such as enkephalin and GABA that are released, right? When it comes to enkephalin and GABA, especially the enkephalins, you might have heard about this acupuncture. In case of acupuncture, what happens is that enkephalins would be released. The enkephalins are nothing but endogenous opioids. Yeah, you have exogenous opioids, that is morphine and related substance, whereas endogenous opioids are these enkephalins. Whenever enkephalins are released, they improve our immunity, and not only our immunity, they also decrease the release of these neurotransmitters concerned with pain, like substance P, glutamate, CGRP. All of them, they are their release is inhibited by these both exogenous and endogenous morphine-like substances. Under endogenous, we have enkephalins. Under exogenous, we have morphine and related opioids. So I want to just, sorry, I'm sorry. Uh, Amina Garu, can I, this one is really bothering me. That is uh, waiting room. That is disturbing.
Yes, sir.
Yeah.
Yes, sir. I am admitting the candidates, sir, participants, sir.
Yeah, no, what, that particular dialog box is blocking my view of the slide.
Okay, sir.
I don't know
I'll mute
how
the
to.
chat box, sir. Okay, sir.
Yeah, no, it's not the chatting box, but yeah, now I pulled it aside.
Okay,
Right.
sir. Thank you, sir.
Now,
Thank you, sir.
right, thanks. Now, coming to the central sensitization, you have the release of glutamate, and this glutamate, it acts on these uh, NMDA receptors, right? Glutamate acts on N-methyl D aspartate receptors. And you might have heard about this long-term plasticity, LTP, or synaptic plasticity. Synaptic plasticity, here, let me tell you that whenever there is a major change that is going to occur in the nervous system, it would be etched. Etching means it's something like engraving or sculpting. You might have seen that our students, they write their names on the benches in the classroom, and some of them, they go to a higher level. Instead of just writing, they try to engrave their names. Mohan, Krishna, they try to sculpt their names. Means they try to make it permanent. So here also the changes would be permanent. So in this, whenever there is a change that is going to be permanent, that is going to fall under the category of glutamate. Glutamate is known for it's an excitated neurotransmitter known for long-term potentiation or synaptic plasticity. So also when there is constant damage or chronic, in case of chronic pain, right, which is which is tagged with the disease, then there is going to be an abnormal response. So that's how it is going to be. So so there would be a change, or there would be a permanent change that occurs in the nervous system. What happened? This got just 1 minute. Yeah. Now, able to see, so you are able to see this cannabinoid receptors over here. Mu opioid receptor. MOR is nothing but mu opioid receptor, right? So they are going to act on NMDA, and what you have neurokinin 1 receptor and AMPA receptor, right? And here the ultimate, this one is that there would be synaptic efficacy means the continuous release of glutamate or the pain transmitters would result in synaptic efficacy, strengthening of synaptic efficacy, or it's also called as synaptic plasticity, right? So this is what it is going to be like. Pain stimulus, and you have the synaptic gap, right? And when pain stimulus is there, the neurotransmitters are released, and then this is carried on further, right? Yeah. So, and then this is one good slide on this ascending pain pathways to the spinothalamic tract and to the cerebral into the somatosensory cortex, and this is the descending pathway, right? So you are able to see that what, you know, the information is once again passed back, right? So just let me move this waiting room business. I feel that when it comes to when in case of classroom and webinar, there is no difference. We as faculty members or teachers, we feel that if it is online, it's okay. But if it is online and if it is a movie or something like that, it's okay. But if it is related to subject, the same this one means people they would be pouring in, they would be joining us at their leisure, right? But if it were to be a movie or something like that, then certainly they will take care to be present 5 minutes before, right? Not for the subject. So it's everywhere, right? Secretion now. If you just, I was mentioning about these endogenous opioids, which are released whenever there is this acupuncture or acupressure. That's why you find that most of the time, if you happen to visit a showroom, shoe storeroom, a Bata showroom or some showroom, you find that uh, there are sandals, there are there are these sandals with pointed or blunt projections, pointed or blunt projections. Actually, they help in releasing these endogenous opioids, right? So then there would be pain inhibition via this endogenous opioid system, right? And another important pain inhibitor is noradrenaline. As far as classification is concerned, we say that noradrenaline is excitatory because of its prominent beta 1 action, because of prominent beta 1 action, right? And but here, when it comes to when it comes to the central nervous system, here you find that noradrenaline is a chemical, is an inhibitory chemical messenger, right? So once again, I want to remove this waiting room. Not able to do that, right? So what are the neurotransmitters that are involved? Yeah, what are the neurotransmitters in descending modulation of spinal nociceptive processing? Yes, there has been pain, the impulse, it has been transmitted to the somatosensory cortex, and there the brain, the CNS has perceived that it is a sensation of pain, and then what the inhibitory neurotransmitters are norepinephrine, serotonin, dopamine, opioids, GABA, cannabinoids, and adenosine, right? And as I mentioned earlier, and the facilitation is through substance P is for pain, and glutamate. That's how we can easily remember that glutamate, nerve growth factor, and cholecystokinin. All of them, they facilitate pain, whereas these transmitters, they inhibit pain. Yeah. Now, coming to some of the areas in the brain, you are able to see this F, that is the cerebral cortex. It is involved in the perception of pain. And then here you have the limbic system, which regulates the pain threshold and emotional reactions. Pain is always associated with emotional reactions. And then you have this hypothalamus and pituitary gland. Here you have the hypothalamus, and this is the pituitary gland. Here you find that there is an endocrine or hormonal response, and the best example of the best thing that happens is here is that there will be release of these beta endorphins, right? Enkephalins and endorphins, as I told you now, they are the endogenous opioid substances that are released, right? And thalamus, this is the thalamus, this is the hypothalamus, then this is pituitary, hypothalamus, and the thalamus. And here, this thalamus is the relay station, and it distributes signals to various areas of the brain. From the spinal cord, it receives signals, and these signals are further transmitted into the cortex so that the pain can be perceived. So, and the medulla oblongata. Here you have the medulla oblongata, and this oblongata has the respiratory and the vasomotor center. And whenever it gets stimulated, you find that there is an increase in respiration and cardiovascular activity. And then you have this the reticular formation just above the medulla oblongata. You have this reticular formation, and this reticular formation, it affects consciousness, and there would be mild whenever there is consciousness is associated with pain. And if a person is emanating, or if he is coming out from anesthesia, right? The patient has undergone some surgery, right? Now, pain makes the patient conscious, right? So, but at times, if severe pain leads to unconsciousness, right? So this is what I was saying, that that pain and emotion, both of them, they are interlinked, and emotion is processed by the limbic system, right? So whenever there is chronic, there will be sleep disturbances, depression, anxiety disorders, weight loss or gain, and impaired quality of life, right? So these are some of the behavioral indicators. Yeah. So these are the behavioral indicators, that is appetite, activity, grooming. We keep our hand in the area where the pain is immense, and then we go on we go on grooming that area. So decreased appetite, decreased activity, there will be aggression, facial expression would change, and many times there will be vocalization. Uh, People will emit that sound. Mm, mm, mm. So appearance, yes. Posture, response to handling, yeah. All of them, they are uh, affected, right? You feel tender, right? When it comes to lab animals, they are this is what is seen, right? Just let me see. Yeah. In case of human beings, you find that this is the scale, Wong Baker scale, which would assess the pain, right? And this is the tool that is found, that is used. That is, you have from 0, that is no pain, to worst pain possible, right? 0 to 10, right? Yeah, you are able to see that the person is also crying, right? And in case of lab animals, these are the ones that we take into consideration. Orbital tightening. You are able to see here in normal, this one, the animal is able to see properly, but whereas here you are able to see that there is tightening of this orbit, and there could be nose bulge, cheek bulge, ear position also changes, right? And there would be a change in the whiskers. And actually, these whiskers, in case of rodents, they function as antenna, right? And that's the reason why whenever these rodents they try to escape, they take the help of these walls or or some structure, and they with the these whiskers, when they come in contact with these walls or the corners, then that's then it starts running along the walls, along along the corners, right? So these whiskers they help as antenna, right? And coming to the physiological indicators of pain, there could temperature, pulse or respiration could increase. There could be weight loss, blood cell count, blood cell structure, cardiac output, and blood flow. All of them they are affected. And more than that, we are interested in biochemical indicators of pain because ultimately our aim is to produce a good thesis, isn't it? Right? Uh, Especially when it comes to pharmacy education or medical education, our goal and aim is to have a very good thesis. So biochemical indicators of pain, corticosteroids, catecholamines, thyroxine, prolactin, endorphin, ACTH, glucagon, insulin, vasopressin, and substance P. All of them, they are the biochemical indicators. Coming to the pharmacological remedy, you have NSAIDs, that is non-steroidal anti-inflammatory drugs, right? And then opioids, alpha-2 agonists like xylazine, meditomidine, D-meditomidine, cannabinoids, local anesthetics like lidocaine, anti-epileptics, carbamazepine, antidysrhythmics, tricyclic antidepressants, amitriptyline, decimipramine, and so many tricyclic antidepressants. Of course, I have a slide on that. Noradrenaline reuptake inhibitors. MOR is mu opioid receptor, and NRI is noradrenaline reuptake inhibitors. Right? We were discussing that when it comes to the central nervous system, noradrenaline acts as a pain inhibitor. It inhibits pain. So you have a good example called tapinatatol. So this is one drug which inhibits the uptake of this noradrenaline. Even tricyclic antidepressants, they also do the same. Now, coming to the brain, site of action of these drugs. In the central pool, you have the opioids, reuptake inhibitors, alpha-2 agonists, GABA agonists, local anesthetics, sodium channel blockers, selective calcium channel blockers. Ziconotide is a very good example. NMDA antagonist. Coming to the peripheral, NSAIDs, local anesthetics, TRP1 receptor antagonist, bradykinin receptor antagonist, selective sodium channel blockers, calcium channel blockers, and opioids. So at the nociceptor level, means at the periphery, these are the drugs that act, and at the spinal cord and in the brain, these are the drugs that are going to produce inhibition of pain. So when it comes to, as I told you that I would like to dwell a little bit more on neuropathic pain. So when it comes to neuropathic pain, the major changes that take place are in ion channel function. Ion channel function and its expression, it undergoes a change. And then the second change that takes place is in the nociceptive neuronal function. You find that there is a change in nociceptive neuronal function. and also in the inhibitory interneuronal function. Actually, these inhibitory interneurons, they are supposed to inhibit, but you find that there is excitement, means the inhibition is lost and excitation remains. Hence, you find that there is this pain. The pain pain takes over. So in neuropathic pain, you find that there is changes in the ion channel function as well as its expression. The expression could be more, right? And that's the reason why we use channel antagonists, sodium channel antagonists, calcium channel antagonists, and also a change in the nociceptive neuronal function and the changes in the inhibitory interneuronal function, right? And this is a good slide that I could procure as far as neuropathy is concerned. This is trigeminal neuralgia, and I think you remember one famous actor of our times. He was diagnosed with this trigeminal neuralgia, post-herpetic neuralgia, peripheral nerve injury, peripheral nerve injury and pain. Uh, and then you have painful polyneuropathy. You are able to see stalking and globe, right? Just like the stalks and globes, you find that there is peripheral there is painful polyneuropathy, and you also have painful radiculopathy, right? And here you have coming to the central area, you have neuropathic pain associated with spinal cord injury, right? What and it could be anything, right? And then you also have the central post-stroke pain, right? A stroke is always a stroke at times is followed by pain. So you find that what, if what if there is a change in the phase due to stroke, and then you also find that there is this peripheral is that there is neuropathy, right? And even in multiple sclerosis, you find that there is pain associated with that, and the pain is along the spinal cord. Yeah. Now, so on one side you have one of the recent articles in Nature review. It has been it has come out with the involvement of the immune mechanisms in pain. Still now we were just concentrating only on the neurotransmitters, how to block the neurotransmitters, how to block what how to block the release of neurotransmitters and all that. But here we have another one, that is you have uh, the blood-brain barrier, and you also have uh, the neurons, and then as part of the as part of pain process, you have substance P and CGRP released, and they are and they act on the blood vessel, and then you have a host of inflammatory mediators that are released, which are likely to attract the T cells, the mast cells, the macrophages, and the neutrophils, right? And yeah, now. As part of cancer, as part of chemotherapy, and right, spinal cord injury, arthritis, and even in the in the neuropathic pain, or the damage to the neurons, you have these neurotransmitters that are released, that is ATP, glutamate, chemokines, proteases, and WNT ligands. I think in the future, people would be concentrating on these chemokines and proteases, right? And how what can we have these chemokines and proteases? They are involved in inflammation, neuroinflammation. Hope you are able to follow my cursor. Neurotransmitters, chemokines and proteases, WNT ligands, right? So then these neurotransmitters, they are responsible for the production of neuroinflammation. So there would be activation, proliferation of glia, microglia, as well as astrocytes, and then there would be infiltration of the immune cells, and this there is infiltration of these immune cells and activation of MAP kinases, and these activation of MAP kinases, they are responsible for the release of pro-inflammatory mediators and gliotransmitters. So here you see that there are a good number of chemokines and cytokines, and also growth factors, proteases, WNT ligands, and gliotransmitters. So once again, here you could find that the primary occurrence coming from the periphery, they have caused the release of this, and increased blood brain permeability. They have caused this neuroinflammation. This neuroinflammation in turn would cause the release of these chemokines, cytokines, growth factors, and all other pro-inflammatory mediators. And now with the help of these pro-inflammatory mediators, there would be further inflammation. So this could be a vicious cycle which needs to be broken. And ultimately, as I told you, that there will be release of glutamate, and this glutamate is responsible for synaptic plasticity. Of course, hope you are able to follow the cursors. So this is responsible for synaptic plasticity. This is the etiology, means these are the various conditions, and then you have the neuroinflammation, and the neuroinflammation ultimately resulting in release of glutamate and causing synaptic plasticity. And this synaptic plasticity is has this increased excitation and decreased inhibition. There would be an increase in excitation and a decrease in inhibition, right? So actually, we want inhibitory pathways to to be more prominent rather than excitatory pathways. Ultimately, so this results in chronic pain, that is neuropathic pain, and we have oh, just 1 minute. I want to. So yeah, right. So right. So cytokines, anti-inflammatory cytokines such as IL-4, IL-10, TGF beta, and also you have certain substances like resolvins, protectins, and lipoxins, which inhibit this synaptic plasticity. So ultimately, synaptic plasticity needs to be taken care of. So we have a good area to concentrate upon. These are the inflammatory and immune mediators that that are listed out under under the development of chronic pain, right? Right. So these are the emerging pro-inflammatory substances. So you have a host of chemokines, metalloproteases, cathepsins, and WNT ligands, and all of them, they are involved in nerve injury. So the current research is focused on trying to come out with various anti-inflammatory or the various drugs or drug targets that could help in blocking these particular pro-inflammatory mediators. So coming to these anti-inflammatory pro-resolution lipid mediators, it is called PRLM, pro-resolution lipid mediators. Here you have protectin D1, resolvin, and lipoxin. So they are going to inhibit the TRP, the TNF signaling, prevent glial activation, and also reduces established inflammatory pain and neuropathic pain. So here, one good dietary source is this fish oil, which consists of good amount of this inflammation resolving lipid mediators, right? So what was you have this protectin D1 receptor over here, and this prevents the release of glutamate. So when glutamate release is inhibited, ultimately synaptic plasticity is inhibited, right? So and we also have voltage gated calcium channels, which are responsible for this chronic pain, and the ziconotide, pregabalin, and gabapentin, all of them, they fall under this particular category of inhibiting these voltage gated calcium channels. So you have now what this is a good um, um, structure of this voltage gated calcium channel. You have nitrendipine, isradipine, devapamil, and deltaazine acting at this level, right? Uh, yeah. Yeah, these are some of the available pharmacotherapy for the neuropathic pain. Tricyclic antidepressants like decimipramine, uh, nortriptyline, amitriptyline, clomipramine, and imipramine, right? And we know that um, they increase the concentration of norepinephrine in the central nervous system, and we also discussed that norepinephrine acts as an inhibitory has an inhibitory role to play when it comes to the nervous system, right? And you also have serotonin, noradrenaline reuptake inhibitors, duloxetine, and venlafaxine. So all of them, they also act as reuptake inhibitors. Just now, I was mentioning about this calcium channel, voltage gated calcium channel, voltage gated calcium channel antagonist, right? This calcium channel is present in the presynapse, and this is responsible for the release of this glutamate. So, whenever these calcium channels are blocked, then calcium entry is blocked. If calcium is not available, then there is no fusion of the synaptic vesicle with the presynaptic membrane, and then the subsequent release of the neurotransmitter. So that's where we have these wonderful drugs, gabapentin, enacabril, and pregabalin. And we also have sodium channel blockers, that is lidocaine, and we have TRPV1 agonist, that is capsaicin high concentration, which is used as a patch, right? And then we have opioids such as tramadol, which has both actions. That is, it is a mu receptor agonist, and it is also a monoamine reuptake inhibitor, right? And we also have morphine and oxycodone. But the role of opioids seems to be limited. But calcium channel agonists, yes, and serotonin uptake inhibitors, yes, tricyclic antidepressants, and we also have another one, that is botulinum toxin A. And botulinum toxin A, it is responsible for inhibition of this acetylcholine release. If you just remember your neuropharmacology, the presynaptic vesicle, which contains a neurotransmitter, it has to fuse with the presynaptic membrane, and then it has to release ACH. But the docking proteins, which are responsible for the docking of the synaptic vesicle with the presynaptic membrane, they are hydrolyzed by this botulinum toxin. So when there is hydrolysis, you don't find the further release of this botulinum toxin, right? And botulinum toxin is injected at the known site. And this is one slide which has the analgesic targets providing clinically validated efficacy. One problem is that because of the lack of time, I'm just having up. One problem is that preclinically we may come out with good number of drugs, but clinically they are found to be not efficacious, right? So you have so many analgesics which have proved their clinical efficacy. Ziconotide, calcium channel antagonist, gabapentin, the same calcium channel antagonist acting on alpha 2 and delta 1 membrane subunit, right? You have this 5-HT1 agonist, and also, of course, we have seen all the others. Voltage gated sodium channel carbamazepine, which is an anti-epileptic, right? And right, new targets. These are the new targets: nerve growth factor, tyrosine receptor kinase A, sodium channel blockers, uh, opioid receptors, kappa opioid receptors, avoiding central dysphoria. Kappa is known for its dysphoria, and we want to avoid that, and still we want to use that as we want to avoid the central dysphoria, and then we want to use it as a peripheral agonist so that it could inhibit the release of um, the pain transmitters, right? Yeah. Now, coming to the deficiencies, as far as our research is concerned, we find that genome-wide approaches and unbiased genome-wide approaches for screening of targets is not taking place. That's what the literature says, right? And one thing I do agree is that instead of targeting a single target, instead of focusing on a single target, we can also have a multiple target approach, multi-pronged approach, so that the treatment could be effective. Today, pain management is uh, pain management is on the is flourishing. We have pain clinics. We used to have what in the yesteryears we used to have a single clinic where everything used to be managed. No. Now you have pain clinics. If the patient is suffering with cancer pain, you go to the pain clinic where you are administered drugs, and then that will subside your pain. So this is what happens most of the time. This is what happens, right? And coming to the solutions, omics profiling of the cells, especially of the neurons that are involved in inflammation or nerve injury, and then you can also have this genetic background, right? See, genetic backgrounds as to only why only a subset of people or a group of people are feel more pain, and why others do not feel the same pain, right? And and in this you can use human neurons derived from stem cells for disease modeling and also phenotype screening. Sophisticated means like optogenetics, imaging of large neuronal populations in awake and unrestrained animals. Generally, whenever we are going for imaging, we go for restrained animals. But actually, it has to be unrestrained animals. Then only that would be a little bit in close proximity to the humans. And then you have the measures of behavior with analysis based on machine learning and artificial intelligence. Today, whatever is the case today, it's artificial intelligence and machine learning, right? So, of course, we as pharmacologists, we are with computer-aided drug design and other platforms, we are already into this artificial intelligence and machine learning, and that can be adopted to finding solutions for pain management. Preclinical models that are better surrogates, that would be a wonderful option, right? If you have a better model and which is very much in close proximity to the human disorder, I think that would be really beautiful. With this, a small gist of the um, current topics that are running in pain management, I close my talk. And I don't know whether it was creating pain for you or it was soothing for you, right? That's why I ended my talk with the slide analgesic or analgesic, right? So thank you very much. Thank you very much for your patient hearing.
Thank you, sir, for giving a valuable and knowledgeable session on novel therapeutic approaches in pain management. Thank you so much, sir.
Thank you. Thank you.
Sir, there are some questionnaires sir, from the participants. Shall I ask, sir?
Yeah. You can. But I'm not able to see my this one. How I lost my video.
Yeah,
How do I?
It's just a general questions, sir.
Okay. One
Sir,
kept. I kept this out of your way. Some dialogue popped up. Okay. Whatever. But one thing I wanted to say is that pain. Of course, we have n number of drugs when it comes to pain, and most of the mechanisms are known. Means, for example, if it is mu opioid receptors, mu opioid receptors. What they do, they just try to decrease the release of pain transmitters at the presynaptic level, right? So when it is really when just now I was talking about calcium channel antagonists. So also this if you just look at one of the slides I showed you, from the periphery to the spinal cord, and from the spinal cord to the supraspinal centers, so that the pain impulse is processed, and then through the descending inhibitory pathways, the right message is passed on. So here, if you look at the mu opioid receptors, they try to prevent the release. Calcium channel antagonists, they try to prevent the release. Norepinephrine and serotonin reuptake inhibitors, they try to increase the levels of norepinephrine and serotonin, so that ultimately you find that the inhibitory the inhibition in the central nervous system here is our top priority, because under the influence of glutamate, excitation is taking place. We want to suppress that particular activity, right? And then we want to increase inhibition. So everything is towards inhibition of the nervous system. For the best example would be GABA, diazepam. What does diazepam do? Just open the chloride ion channel, cause the entry of chlorine inside the neuron, so that results in hyperpolarization. Your questions, Amina, I keep on talking and talking. That's that's one of the professional hazards with teachers. They go on
yes, sir,
talking.
yes, sir. And it is very informative session, sir.
I don't know. I think see, as a coordinator and
no, sir, it's our pleasure, sir, to be you as a speaker, sir.
Students have to give the feedback. Kindly share the feedback.
Yeah. At the end of the session, I'll share the feedback, sir.
Okay.
Sir, just a question, sir. In autophagy, has the protective role in a neuropathic pain management?
To be precise, I haven't seen autophagy. Yeah, but with my knowledge, I feel that autophagy has a protective effect, because autophagy takes place. See, there are three: autophagy, apoptosis, and necrosis. Isn't it?
Yes, sir.
Yeah. Especially to the student who posed the question, right? Autophagy, apoptosis, necrosis, right? These three conditions are seen, but when autophagy occurs, and when apoptosis occurs, and when necrosis occurs, it all depends upon the mitochondrial damage. If the mitochondrial damage is moderate, right? Is minimum. I don't say moderate. If it is minimum, then autophagy takes place. Means when autophagy comes into the picture, when when the neuronal cell thinks that yes, this cannot be done, there is no way. It's something like a firefighting a firefighting process. A fire has occurred, and you want to dose out the fire, right? And then within your reach, you do, before it causes damage. So that's what autophagy is all about. So the mitochondria have been damaged, and then autophagy takes place, right? there is mild damage to the neuron, then automatically autophagy takes place. Apoptosis takes place when there is moderate damage of the mitochondria, and necrosis takes place when there is severe damage of the mitochondria, right? So ultimately, autophagy and apoptosis are welcome, but necrosis is not welcome, because in case of necrosis, it's something like a incendiary bomb. When in case of incendiary bomb, when the bomb explodes, the shrapnel, the nails, or the other iron filings that are there in that, they go they go with a great speed and try to injure injure those who are present in the surrounding. Whereas a autophagy and apoptosis, it is within the house, no one knows. So autophagy and apoptosis, they are what, they are desirable as far as my little knowledge goes.
Yes, there are so many questions, sir, but I will asking another
Yeah,
question, sir.
Dr. Amina,
Sir.
you can put them in this
Chat
one.
box.
So
Okay,
not only now, otherwise also, maybe other people, they have shared their phone numbers or email
Yes, sir.
IDs at the time of registration,
Yes, sir,
so
yes,
that I'll try to answer all of that. No
okay, sir.
problem at
Right,
all.
sir.
No,
Okay, sir.
no problem at all.
Okay, sir. Thank you so much, sir.
Thank you.
Thank you, sir. And now I
Thank
would
you.
like to hand over to the convener of today's webinar, Dr. A. Lakshman Rao, sir, to share his views. Thank you, sir. Now it's a
Thank you.
closing session.
Yeah.
Thank you for all the participants for their active participation. Hope this session gave you knowledge about novel therapeutic approaches in pain management. Thank you very much, Dr.
Thank
B.
you, thank you.
Kalakumar, sir. Thank you so much,
Thank
sir.
you. Thank you.
There is
Thank
a
you
small,
very-
sir.
Thank you very much for giving me an opportunity to refresh myself and to know the
Sir,
latest that's
it is
happening.
our honor, sir.
No,
Thank you so much, sir.
thank you very much.
There is a small note for all the participants. Please submit the feedback form on or before 4 p.m. today. The link is available in the description tool in the YouTube, and the link will be active only up to 4 p.m. today. And e-certificate will be generated and will be issued only to the participants after submission of feedback. Thank you and have a nice day. Thank you so
Yeah.
much, sir. Thank you all the participants.
Dr. Amina, please send the questions too.
Sir, right, sir. I will send, sir. I will mail.
Right.
I will mail it to you, sir. Thank you so much, sir.
Thank you.
I am ending the session, sir.
Yeah.
Thank you, sir.